This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you.
This is going to be Chapter 19, Disorders, Abdominal Hemorrhage. Key concepts. Upon completion of this chapter, you will understand that bleeding of the GI tract can occur at any point along its entire length. How the ligament of Trenz serves as a division between the upper GI and the lower GI tract. That GI bleeding can be slow, leading to few signs and symptoms, or catastrophic, leading to rapid hypoperfusion and death. The knowledge that the paramedic responsibilities include the recognition of the potential for hypoperfusion, interventions to prevent or improve hypoperfusion, and appropriate transport. Chief concerns. Categories of gastrointestinal bleeding. We have upper GI and lower GI bleeding. Upper gastrointestinal bleeding include the esophagus, stomach, and a portion of the small intestines up to the ligament of Trenz. The ligament of Trenz is a thin muscle connecting the junction between the duodenum and the jejunum to the connective tissue surrounding the superior mesenteric artery and the coleoic artery. Lower gastrointestinal bleeding is after the ligament of Trenz, up to the anus, and figure 19.1 in your book is going to be gastrointestinal hemorrhage. Those are some of the structures we were talking about, and what I'm going to do is right where the duodenum turns into the jejunum. Right there is a ligament that kind of holds that and actually attaches also mesenteric artery that's around here, and the connective tissue that holds all of that is considered the ligament of Trenz. Anything above that is considered an upper GI bleed, and anything below that is considered a lower GI bleed. Upper gastrointestinal bleeding originates from the esophagus and extends to the middle of the intestines. Common disorders seen up here are a Mallory-Weiss tear, a longitudinal tear in the esophageal or stomach wall, Bohave syndrome, full thickness tear, perforation of the esophagus, Hammond's crunch, crunching sound caused by subcutaneous emphysema. Gastroesophageal reflux disease results from a reflux of the stomach acids on the lower third of the esophagus. Reflux esophagitis results from acid backwash or irritation in the esophagus. Hiatus hernia, outpoaching of the stomach through the cardiac opening and into the thoracic cavity. Hepatorenal syndrome, esophageal varices, caused by swelling of veins in the esophagus and or stomach, and we'll talk about portal hypertension and stuff. The next term on this is going to be portal hypertension. May occur when cirrhosis is present in the liver. Blood that would normally flow through the liver readily unimpeded is blocked. And figure 19.2 is going to be hepatic blood flow. What you need to get off of this is everything that is from the intestine before it goes back into the inferior vena cava or the vena cava is filtered by the liver. So if the liver is fatty and has kind of a clogging, it'll back up the flow of these, causing them to protrude. If this occurs in the esophagus, you'll have outpouchings, so to speak, of veins. And this can very easily give you an esophageal varices. Lower gastrointestinal bleeding originates from the bowel, distal to the ligament of Trenz. Small percent proximal to the ligament of Trenz, though, still can occur when a lower GI bleed. Acute lower gastrointestinal bleeding can result in hemodynamic instability. It should be treated as an emergency. Figure 19.3, lower GI bleeding occurs below the ligament of Trent's, and we'll see a picture of this. This is the ligament of Trent's. It's a supporting factor right here. So in between the duodenum and the jejunum, and all of this here, this mesenteric area that houses the mesenteric artery is considered the ligament of Trent. So again, anything that's above that is an upper GI bleed. Anything below that is a lower GI bleed. Causes of lower GI bleeding. Angiodysplasia, which is vascular malformation where enlarged capillaries and veins in the bowel wall become fragile and bleed. Dysentery, infection of the digestive tract that leads to frequent passage of diarrhea that may contain blood and mucus. Inflammatory bowel disease, group of conditions including Crohn's disease and ulcerative colitis. Crohn's disease is a disease of the lower intestinal tract. Can involve any part of the gastrointestinal tract, though, from the mouth to the anus. For this reason, also called regional enteritis, thought to be an autoimmune disease. And ulcerative colitis, limited to the large intestine or colon, causes unknown, more common in the northern climates. Irritable bowel syndrome. Diarrhea is prominent, constipation is predominant, or pain predominant. Tumors and polyps. Polyps are small masses or tissue inside the intestine, which can be benign, familial, or even precancerous. Tumors, small masses of abnormal tissue inside of the intestines. They also may be benign, non-cancerous, or malignant and cancerous. Intussusceptions. Bowels can inwardly telescope on themselves. A volvulus is an abnormal twisting of the gut caused by an acute loss of blood supply. Diverticulitis, pockets of diverticula develop in the colon walls. Meckel's diverticulum, a rare congenital condition in which the gastric lining is found in another inappropriate portion of the gastrointestinal tract. Hemorrhoids, swelling of hemorrhoidal veins. Rectal fissures can be caused by a tear in the rectal lining, which may occur due to the passage of hard stool or the insertion of objects into the rectum. History. Focus on recent bowel movements and past episodes of bleeding. Considerations for this. Patient's description of the bleeding and color distinctions. Melena, which is stool that is dark due to having been digested by the stomach acids. Or hematochezia, which is bright red blood per rectum. Bowel movement history is important. Disorders and medication history. Anticoagulants can worsen minor bleeding. And salicylates have long been implicated in causing GI bleeds. Next table we're going to look at is 19.2, stool color and consistency. And blood amount in the stool can be caused, blood around the stool can be caused from hemorrhoids, rectal bleeding, blood in the stool, colon cancer, diverticular bleeding, black stools. This can come all the way from the top. Epistaxis or nosebleed, esophageal varices, gastric varices, any GI abnormality like cancer, Pepto-Bismol, aspirin, or iron supplements. Pale yellow stool, gallbladder, bile acid synthesis problems, biliary tract cancer, cholangitis, which is an infection of the common bile duct, or cholecystitis, which is a gallbladder infection or gallbladder inflammation, hepatitis, pancreatic insufficiency, or pancreatic cancer. This is kind of continued here. Green stool infections like Giardia, Salmonella, and rotavirus. Foods, especially with chlorophyll, such as spinach. Mucus in the stool, infections, enteritis, dysentery, ulcerative colitis, Crohn's disease, inflammatory bowel disease. And then stool odor. It may be a normal variant. It may be associated with recent ingestion. Steatorrhea is excessive fat, the feces, to the point where the feces even floats. And celiac disease can cause very ugly stool odor. On examination, initial focus, we should look for the presence of shock. No signs of shock. Assess the orthostatic vital signs. And that would be laying them down taking the blood pressure and pulse, setting them up, taking the blood pressure and pulse, and then standing blood pressure and pulse. If they become faint and syncopal, they have a positive orthostatics test. More than a 20 millimeter variance in blood pressure, or 10 to 20, depending on which version you actually see, on the heart rate, it increases and is sustained. That would be a positive orthostatics. Commonly, we look at the blood pressure, though. Considerations on this: patient positioning, we should have them in the supine position. Accidental exposure prevention, proper draping. Abdominal examination, we should look for masses, scars, signs of liver disease, and or bruising to rule out trauma. Assessment: blood in vomitus or stool, GI bleed of unknown origin, and paramedics preparation, prepare to treat the patient for shock. Consider the capabilities of the destination hospital. Can they actually handle it? As far as treatment considerations go, we should provide supplemental oxygen administration, establish IV access, consider drawing the blood for the hospital, administer an antiemetic for nausea, something like Zofran or whatever we have on the truck, if they're nauseated. Nasogastric tubes, they kind of serve several purposes, and one of the purposes is to remove blood from the stomach so that nausea isn't created. In evaluation, hemodynamic unstable patients, aggressive fluid resuscitation may be needed. Clinical goal is to maintain cerebral perfusion pressures without increasing the bleeding. On disposition, lower GI bleeding cases are about 10% and generally require emergency surgery. Destination depends on the availability of the operating room and the actual surgeon. In conclusion, gastrointestinal bleeding, relatively common condition, typically affects middle-aged and older individuals, can also affect younger people with strong alcohol use history and several other conditions. Insidious gastrointestinal bleeding, common cause of syncope, weakness, and fatigue in the elderly. Acute gastrointestinal bleeding can be massive and life-threatening. Challenges the paramedics' resuscitation skills. Knowledge of the pathophysiology of gastrointestinal bleeding, along with keen assessment and observation, allows the paramedic to rapidly identify the critically ill patient with the gastrointestinal bleed and aggressively manage the patient. References for this were taken from Myers, Professional Paramedic, Volume 2, Medical Emergencies, Del Mar Learning. And if you have any questions concerning this chapter, feel free to give me a call. My name is Roy Smith, roy.smith@redlandscc.edu or 405-219-7613. Thank you.